3.0. I'm Nikki Anderson, the Stroke System Nurse Specialist, and I'm joined here today by my colleague Michelle Gray-Ansari, the Designation Coordinator. Before we get started, I wanted to acknowledge that we received a record amount of evaluations from last month's webinar, so thank you. We are thrilled with not only the amount of responses, but also the detail in which you provided feedback. The evaluations were filled with future ideas for content, which helps us to bring valuable and useful information to you all. We kindly ask that you again complete the evaluation at the conclusion of today's webinar. We appreciate you taking time out of your day to join us here, and thank you in advance for taking a few minutes to complete that evaluation. As usual, your lines have been muted upon entry. Ali Fuji, the registry coordinator, is also here with us in the room today, and she will be monitoring the chat. Please feel free to type questions into the chat throughout the webinar. Instructions for how to access and utilize the chat feature are listed here on this slide, and we'll save all questions until the end of the content. If we happen to run out of time, please don't worry, we will address your questions in our follow-up email. Today we will cover all things Designation 3.0. We will review the purpose of acute stroke ready hospital designation, the application process, designation criteria, and resources available to support your program. We will also share some tips and tricks in preparing for a successful site visit and some common findings. Now we'll talk about the purpose of acute stroke ready hospital designation. The Brain Attack Coalition guidelines were published by the AHA in 2013. In the guidelines, it states that stroke centers are to provide vital infrastructure, expertise, protocols, and monitoring care in accordance with nationally recognized guidelines and performance expectations. The goal is to make sure that a patient receives the proper level of care in the most expeditious and efficient manner. The main focus is around emergency department care and the ability to assess, treat, and transfer patients appropriately. The acute stroke ready hospital care elements within the Brain Attack Coalition guidelines are really the acute stroke ready designation criteria that you all know so well. They are the foundation of each and every one of your stroke programs. So what you see here in this slide is unchanged as we move forward into 3.0. Yet, some of the submission requirements have been adjusted along the statewide stroke system journey. These maps pictured here are really powerful. I know you've seen them many times, but they demonstrate the success and hard work you have all shown through designation. Knowing that Minnesotans' access to timely stroke care has risen from 60% to 96% of the state's population is truly remarkable. Now let's dive into the acute stroke ready hospital application process, history, and what to expect for the next submission round. The first round of designation, lovingly labeled 1.0, launched in 2014. At that time, electronic submission of documents was all that was required. Quickly, by December of 2014, 81% of the state lived within 30 minutes of a designated stroke center. Now, the second round of designations not only included the electronic submission of documents, but also added the site visit component. A lot of preparation and planning went into the design of this aspect of designation. The first site visit occurred in October of 2017, and we've learned a lot along this journey, but are so very proud to report that as of today, roughly 85% of site visits have been completed. 2020 is literally 2 weeks away, and before I discuss the 3.0 application process any further, I just want to pause and say congratulations. It has been an honor to watch all of your programs grow and develop, and through the site visit component, we've been able to see firsthand the amazing things happening throughout the state of Minnesota. It's no easy task to be the captain of any program, and stroke coordinators are awesome, and you have all done and continue to do really important work. We want to thank you again for welcoming us into your hospitals and for working so hard to build and improve upon your stroke program. Now it's time to do it all over again. Heading into 2020, 96% of our state population lives within 30 minutes of a designated stroke center. The 3.0 application process will include minor updates to the electronic submission requirements. The current deadlines of April 1 and October 1 will remain the same. There is a lot of overlap in the outreach and coordination through the designation timeline between Michelle and myself. You'll be hearing from us to 1, let you know your application time period is approaching, to also arrange for and meet for technical assistance and an overview of submission requirements, as well as to schedule your site visit. And this will all happen prior to the application deadline of April and October. In the 3.0, the application itself will include two components, the electronic submission of documents and the site visit. You'll receive one acute stroke ready hospital designation report after documents are reviewed and the site visit occurs to complete successful redesignation or initial designation. Another new component of the acute stroke ready hospital timeline is the mid-cycle review. We started conducting mid-cycles in 2019 with hospitals that received an immediate action at their site visit. And we do plan to continue this process as we move forward, but for all designated hospitals. The purpose of the mid-cycle is to maintain designation readiness, keep us connected to designated facilities, and we want to continue to build trust and foster program growth and development. This is an interactive call. You can expect the mid-cycle call approximately 1 year after your site visit. MDH staff will contact you to schedule the call, and what we will discuss is the implementation and monitoring of immediate actions as submitted if applicable. We will review recommendations outlined in the designation report and discuss ongoing PI efforts and initiatives. And we'll provide you with any updates to stroke care guidelines and new clinical resources that we have to share. And lastly, we'll provide you with time to ask questions regarding designation. We do recommend including staff involved in the support and performance improvement aspect of your program, yet there are no specific staff members required to be on the call except for you as the stroke coordinator. This process will not result in any immediate actions. However, if it is learned that there's no progress being made towards any of the actions and findings and recommendations, further outreach may be arranged. Now we'll navigate through each designation criteria and what the electronic submission requirements are, as well as what to expect during your site visit. Here are the 9 criteria, and good news, they have not changed. Those will remain the same. The first criteria is the acute stroke team. Implementation of an acute stroke team activation log is required, and we do require that all activations are tracked regardless of final clinical diagnosis. Now, the acute stroke team may be staffed by a variety of healthcare personnel. And note that the acute stroke team may also include lab, radiology, pharmacy, and other departments defined by your program. At a minimum, what we require is 1 nurse and 1 provider respond to acute stroke team activation. The activation log was rather new for some programs through the last round of designation. But now that everyone has implemented a log, we'd like to see that submitted with the last 12 months of log cases for the electronic submission of documents. We do acknowledge that some programs use more than 1 log for tracking, and if so, please submit both for review. During the site visit, the review team will ask to see the log and want to have an active discussion as to how it is utilized. The next criteria is written protocols. This criteria shouldn't look too different from the last round. Protocols should encompass care in the emergency department, and review of said protocols should be happening at regularly scheduled intervals, and preferably prior to submission. So what is specifically required to be submitted as part of the electronic submission of documents? The written protocol for your emergency department that includes diagnosis and treatment for ischemic stroke, TIA, and hemorrhagic stroke patients. This protocol should coincide with most recent stroke guidelines, incorporating a process that allows for stroke code activation for patients presenting within 24 hours of last known well. The second thing to be submitted is an algorithm that supports the written protocol and serves as a quick reference for care in the code process. You should also submit order sets that reflect that protocol, and a document that supports inclusion-exclusion criteria for alteplase decision making. For those of you that regularly admit IV alteplase patients, there are a few extra documents to submit. We'd like to see a supporting letter signed by you as the coordinator explaining circumstances in which you admit this population. Please attach the admitting order set and as well your dysphagia screening protocol. At the site visit, the MDH review team will ask to see where these documents are located. They will conduct a case tracer activity that will include review of order sets utilized in the care of stroke patients. The next criteria is EMS collaboration. Now, when I started in October of last year, we'd received feedback regarding letters and obtaining the CEO's signatures on all of them and how challenging that can be. So thank you for your feedback. We've listened and we have decreased the amount of signatures by the CEO that are required. For the electronic submission for EMS collaboration, we would still like to see the EMS stroke protocol for each service that represents more than 30% of your stroke volume. To showcase collaboration, you may also choose to submit the EMS transfer protocol or a letter that details this process. At the site visit, EMS program collaboration will be validated by discussing the EMS's program involvement. Are they included in your stroke committee meetings? Do you provide any feedback, education, PI initiatives in collaboration with EMS? We encourage you to invite EMS staff members to the opening and closing sessions. During the facility tour, the MDH review team will interview staff and would appreciate an opportunity to talk with EMS staff as well. The next criteria, number 4, is education. Education should be provided to the acute stroke team members. Each member of the acute stroke team, all nurses and providers at a minimum, that respond to stroke should receive stroke education at least 2 hours or 2 times per year. You will be required to submit a detailed table of your stroke education plan for the next 3 years. This plan should include onboarding for new hires. Locum providers are also to receive the same education, and it is acceptable to use an attestation letter completed by the provider detailing the date and stroke education completed externally. At the site visit, here's what's new. The MDH review team will request to view your educational tracking system in records. Be prepared to illustrate the educational offerings that have been provided over the last 12 months. The site reviewer will ask to see 1 nurse and 1 provider's records around the case tracer activity time. These are examples of an education plan and locum's attestation letter found in the new designation reference guide, which is currently available online. The next criteria is lab testing capability. Electronic submission includes a scope of service or policy document that includes lab hours, on-site versus on-call with their response time, and the process for stat labs. If the above details are not included in that policy, then a supporting letter is acceptable signed by the Director of Lab. I do want to note here to please update the scope of service or policy documents for the next submission round if you have not done so already. We do plan to eliminate the supporting letter as we move forward. At your site visit, the review team will also ask to speak to lab staff to validate the submitted document. The next criteria, number 6, is brain imaging capability. This supports programs having the capability to perform and interpret brain imaging studies 24/7. Some of you may have had this recommendation or opportunity listed at your site visit. For those of you who have CTA capabilities, we do encourage you to work closely with your primary or comprehensive stroke center partners to implement a process to evaluate patients for endovascular therapy if necessary. For electronic submission, this is very similar to lab. Submit your scope of service or policy document that includes the listed details. Again, a supporting letter is acceptable and it may be signed by the Director of Radiology, so please continue to work on updating those documents. At your site visit, the review team will ask to speak to radiology staff to validate the submitted document. On to the next criteria, which is the most obvious changes from last submission round. Data collection and utilization, which basically means PI. For this criteria, we want you to demonstrate collection of data and utilization of that data for PI purposes. The more the merrier here. Show off what you're doing. At the time of your application, we strongly recommend that you are up to date on data submission in the Minnesota Stroke Registry. We have added a check-in point on our end so that if your hospital is behind on data, we plan to let you know this prior to your approaching deadline. The portal has many reports available for use, and we want you to use what we have to help drive the performance of your program. You will need to submit the door-to reports that we have available in the portal as listed here. Please note, the door-to-provider report is not yet available. And if you do have this data available in a different format, you are more than welcome to submit it that way. You will also, we request that you submit your PI projects, action plans, data tracking, and meeting minutes. Stroke meeting agendas and meeting minutes should be submitted from the last year. And lastly, any case review or feedback forms that you utilize, we'd love to see. At the site visit, there will be data and performance improvement sessions still, which we have a PowerPoint available as a template. Include your door-to-metric tracking reports, and also showcase any other PI efforts that may not coincide with those door-to-metric tracking. For example, dysphagia screening, neurocheck compliance, blood pressure monitoring, that kind of a thing. Criteria 8 is transfer protocols. For electronic submission, include your stroke-specific transfer protocol and a stroke-specific transfer agreement or memorandum of agreement with at least one primary or comprehensive stroke center who have 24/7 thrombectomy capabilities. During your site visit, the review team will facilitate an active discussion regarding the process of transferring an acute stroke patient. Lastly, criteria 9 is the stroke leadership team. Electronic submission includes a letter co-signed by the stroke medical director, coordinator, and CEO attesting to rules. During the site visit, an active discussion regarding those rules and responsibilities of the stroke coordinator or how responsibilities for program components are divided among staff will happen. I'm going to share a few resources that we've updated that are available for you. The first is the 2019 updates, the 2018 acute ischemic stroke guidelines. Please use those to update some of your policies and protocols as you move forward. The Acute Stroke Ready Hospital Designation Reference Guide is newly updated and includes new examples for ideas for each criteria. It is available now on our website, and we have emailed this currently too, so please reach out if you have difficulty finding it. And now I will hand things over to Michelle.
Okay, thanks, Nikki. Now let's take a few minutes and take a deeper dive into the site visit. Nikki's presentation provided you with information for each criteria on what to provide at site visit time. In the next few slides, I will share some tips and tricks that I've gathered across the 77 site visits to date to further encourage a successful site visit. I will also discuss the most common findings that have been identified during the site visit. Thanks for all your hard work over the last couple years. For those of you who are still awaiting your first site visit or those preparing for your 3.0 site visit, please use this information to plan ahead and prepare. First and foremost, please use the resources that are provided to you. We offer a sample opening presentation, a sample PI presentation. We have an agenda and other resources on our website underneath the site visit tab area on the website. Additional support is provided upon scheduling. Also, please ensure your stroke care is up to par with the American Heart Association and American Stroke Association 2018 stroke guidelines and the 2019 updates to that Nikki just talked about. It is ideal to prepare a packet in advance for the reviewers of all materials that support the visit. Copy of the PowerPoint presentation, case lists for the case tracer activity, an education log of what you have provided, and ensure you have the ability to pull education files on the spot of nurses or providers as requested. Remember, beginning with our 3.0 site visit, your second site visit, a reviewer will ask to pull the educational records for one nurse and one provider And this nurse and provider are typically those folks that are working in the emergency department that day that the site reviewer might speak with. A basic but vital tip, inform your hospital team members that MDH will be there for a site visit and on which day. Ensure staff are not only aware of your stroke protocols and clinical best practices, but also where to find those documents, any quick references or algorithms to access during a stroke code to ensure key steps are not missed. If you experience any gaps in talking with your own team about these things, this is a great opportunity to educate your team now, before the site visit, not later. Furthermore, in education, please review your staff education files. This is to ensure your team has received the stroke education per the criteria. Again, your reviewer will ask to see the record of one nurse and one provider. Finally, this has been a hot topic of interest. Please thoughtfully prepare for the case tracer activity by having your stroke case list from the last year, and or your stroke code activation log or stroke PI log works great, highlighted or coordinated, organized in the following categories. Number 1, alteplase transfer patients. Number 2, non-alteplase transfer. So these are your hemorrhagic stroke and your ischemic stroke, no alteplase. And number 3 category, any alteplase patients that you admit and or any other stroke patients you admit. Have that please in the 3rd category. Your reviewer will pick cases from the list and review those charts right alongside you in the electronic medical record. Please do not print the records in full. This is an opportunity to see if documentation in the record is in accordance with your stroke processes and in accordance with current clinical guidelines for the acute care of stroke. To ensure this activity runs smoothly, please have the staff member that does chart review help navigate the charts in the medical record. Also ensure the abstractor is present, whoever submits to the registry, if this is not one and the same person. There is a sample case tracer form, hint, hint, available on our website that the reviewer will utilize to review the cases. So this is a little homework for you before your site visit. Please practice a case tracer using this form. You might learn a lot from that in advance of the site visit. Otherwise, those learnings happen right on the spot. And also, please note, if there happens to be a stroke code activated on the day of the site visit, the site reviewer will shadow the process in place of a chart review. This has and will occur at site visits, and that is okay. Just do your thing, patient comes first. The reviewers will just shadow and prompt ask questions if necessary. Now let's talk about some common findings identified at site visits. There are 4 categories of feedback that findings can fall into: immediate actions, recommendations, opportunities, and strengths. An immediate action derives from unmet acute stroke ready hospital designation criteria or concern for patient safety. An immediate action requires an action plan to be developed, implemented, completed, and submitted back to MDH post-site visit within a specific timeline. Recommendations stem from guidelines, standards, and best practice and are to be addressed by the next designation cycle. That gives another 3 years to thoughtfully fold that into your program and into your care. Opportunities are not required, yet are great opportunities to help improve your program and take it to the next level. Sorry about that. Again, we're experiencing just a couple odd and end little difficulties here. Okay, so let's take a look at a couple examples. I would suggest taking a deep dive into your program and address these potential issues before the visit. Here's an example of an immediate action. As IV alteplase charts are reviewed during the case tracer activity, a few issues are noted. The patient's blood pressure is consistently uncontrolled or not monitored at all before or after alteplase administration, and or Q15 vitals and neuros for the first hour upon alteplase administration are consistently undocumented post-alteplase. These findings raise concern and an immediate action would be identified under the umbrella, the safe administration of IV alteplase per national guidelines. This has by far been the most common immediate actions. You're not alone if you did obtain that immediate action, but knowing this in advance, please make sure that you're taking a look at your care and doing a couple of these case tracers on your own to see if this is occurring and taking time to address that in your PI. And the key word here when it becomes an immediate action is that it's consistent. Pre and post alteplase monitoring raises to level of immediate versus recommendation if every chart reviewed illustrates the same gaps in care and your program's PI or case review process did not identify these gaps in clinical care in advance. This would especially be deemed immediate action if the staff interviewed during the site visit tour could not verbalize the proper monitoring of an IV alteplase patient, nor where they could find references to prompt such care and guidelines. Pre and post monitoring of the IV alteplase patient is of the utmost importance and is the most common finding identified at site visits here in Minnesota. Now let's take a look at a couple recommendations from 2.0 site visits. And remember, recommendations are to be addressed by the next designation cycle. This means that any of these recommendations that were identified in 2.0 are required to be addressed by your 3.0 site visit. And if not, an immediate action may be utilized at that time if it is seen as a consistent problem and not addressed. With the recently, so a couple examples of some common recommendations from this last round of site visits. With the recently expanded treatment window for endovascular treatment of stroke, it is recommended that the hospital implement a process that allows for stroke code activation for patients presenting within 24 hours time last known well. This expansion of stroke code activation may include all suspected strokes or only those with symptomology consistent with large vessel occlusion. It is recommended that this process is developed in collaboration with your telestroke, neurology, and/or receiving stroke center partners. Please reference the American Heart Association, American Stroke Association guidelines. It is an expectation, I want to reiterate this, that all acute stroke ready hospitals are practicing within current acute stroke care guidelines by your 3.0 stroke site visit. Another common recommendation found in this last round is tracking all stroke code activation, not just those that code out as stroke. This provides the opportunity, especially with low volume stroke, to monitor your performance regardless of final diagnosis. If you sought stroke and you activated a code, you want to review your performance on those cases. Don't leave them out of your PI process. This is also a requirement in 3.0. Last couple common recommendations regarding documentation. Ensure you are documenting and tracking the reason for alteplase not given in patients who presented within the treatment window, and also you want to document that endovascular intervention was considered. I'm hopeful that Nikki and I provided you with some key insight into the acute stroke ready hospital designation process as we head into 3.0. For further context and resources on preparing, please visit our website, visit the portal, and contact us. We're always happy to help cheerlead you through this process. Allie has placed a link to the evaluation, or will, perfect, right into the chat. Please take time to fill out the evaluation. And we do have just a couple minutes here, so we're happy to take any questions that have come in.
There was a question regarding the slides, and we will be sending that in our follow-up email.
Yes, all the slides will go out in the follow-up email. Okay. Well, fabulous. Well, thank you for your time and attention today. I hope you have a very safe and warm holiday. This concludes our webinar. We will continue to convene our monthly webinar series on the third Wednesday of each month moving into 2020.
Thanks, everyone.